that end-of-life care is complex and a deeply personal issue. So people living with dementia and caregivers have varying opinions, experiences, and feelings about this topic. The Alzheimer's Society of BC advocates for people living with dementia, their caregivers, and family members to be included in discussions, decisions, and policies that affect them. And that includes medical assistance in dying. So the information shared today is intended to assist and support people living with dementia, together with their families and caregivers, in making informed decisions about their care. And we are incredibly grateful to have Dr. Stefanie Green here with us today to provide an overview of MAiD and discuss the complexities and misconceptions surrounding medical assistance in dying for people living with dementia. So it's my honor to introduce Dr. Green today. So Dr. Stefanie Green has spent 22 years in general practice and maternity and newborn care before changing her focus in 2016 to medical assistance in dying, or MAiD. So Dr. Green is the founding president of the Canadian Association of MAiD Assessors and Providers, is the moderator of their online community of practice, and was co-lead of the Canadian MAiD Curriculum Project. She is a medical advisor to the BC Ministry of Health MAiD Oversight Committee and has hosted several national conferences on the topic. She frequently speaks about MAiD to a wide range of audiences locally, nationally, and internationally, and recently gave a TED Talk titled The Truth About Assistance in Dying. So Dr. Green is the author of the internationally best-selling book, This is Assisted Dying, a memoir about her first year providing assisted dying in Canada. So I would like to officially welcome Dr. Green here today. Thank you so much for being here.
Thank you so much for having me. I'm just going to set up my slides to share with you.
Yeah, and while Dr. Green is pulling up her slides, I just wanted to take a moment to speak a little bit about her book, This is Assisted Dying. So I'm currently engrossed in it. I've been reading it for the past week, and I just wanted to thank you, Dr. Green, for writing this memoir. I just found that you have conveyed the human aspect of medical assistance in dying so artfully by sharing the stories of your patients and their families, as well as what it was like for you in that first year. And I know it's changed my perspective and taken some of the maybe uneasiness around this topic out of it through the storytelling. And I just want to thank you for sharing that with us.
Thanks, I appreciate that. And I want to thank the Alzheimer's Society of BC for the invitation to be here today. It's really a pleasure to be with you and to be with your attendees. I'm not a very formal speaker, but I do plan to speak for the next 40 minutes or so, and then take questions, which I think can be really interesting. If at any time I start to talk too fast, somebody's welcome to tell me I'm doing so. I have a bit of a knack of doing that. But I do really appreciate the invitation, at least as much because we have seen a lot of information about MAiD in the newspapers and discussions with our friends and family around the dinner table. And I find that there's been a lot of confusion and a lot of misinformation and disinformation about assisted dying that we're seeing out there. And I'm hoping that today we can get to some accurate, honest information and help kind of untangle some of the confusion that's out there on this topic. That's really what I hope we can do today together. I'm not going to spend very much time talking about myself. Thank you for that introduction. I think you've hit all the most important aspects. It's probably relevant, though, that you know that I am trained as a family physician. I spent much of my career in maternity and newborn care, which was a passion of mine. And I switched my focus in 2016 when the law changed. So it's been just over 8 years now. I've been working almost exclusively in assisted dying. I do wear a number of hats in this work. I do want to point out explicitly, though, that while I'm tremendously proud to be the founding president of the Canadian Association of MAiD Assessors and Providers, nothing I say today is on behalf of that organization. I speak purely for myself as an individual MAiD practitioner. So I do want that to be super clear. And I do appreciate the shout out to the book. While I would love all of you to buy this beautiful book and have a read or have a listen to it, I think that it's not necessary that you do so in order to get something out of today's talk. I would consider it a worthy companion to today's talk more than anything else. So over the next little while, a short hour, I guess, I'm planning to talk about assisted dying in Canada. I am going to do what I call the foundational information first. Very briefly review how it came to be here. It's important that we understand how it came to be, how it actually works, and we'll understand these kind of foundational pieces first because it will allow us to build upon the parts that we can then focus on, which is the issue of assisted dying and dementia, whether it's possible, spoiler alert, it is, and how that might work and how that might be complicated. We'll talk about some special situations. I'll try to maybe take a quick glance into the future, what might be coming, but I promise to leave lots of time for question and answer because I think that's a very important part of this interaction today. And I do appreciate the nod earlier where you mentioned that this can be a very emotional and sometimes a contentious issue. I don't shy away from that. I encourage anybody and with every perspective to be at my talks, to interact in the question and answer period. As long as comments are made respectfully, I'm not scared of any question, and I encourage your participation this afternoon. So with that, let's start to dig in. There are, of course, a large variety of terms that are used when we read about MAiD, when we hear about MAiD, when we talk about MAiD, when we talk about assisted dying. Depending on who wrote it and what year it's published and where it's being seen, there can be a confusing array of terminology that's used. I think some of the terms that are used are descriptive. I think some of them are pejorative. And I think several of them are confusing. I'm not going to dive deeply into the terminology today, except to say that terminology is important because it creates a context. And correct terminology is very important. So what am I talking about today? Well, you won't be surprised. What I'm talking about, I'm going to use a term called assisted dying. I think it's an umbrella term. And when I talk about assisted dying, I'm talking about what is the legalized, and I believe compassionate end-of-life care that's provided by clinicians who either prescribe and or administer the lethal medications that will safely and effectively end a person's life in specifically outlined safeguarded circumstances, which always include the explicit request of a competent adult. So there's a lot of words in there, but each one of them is important. And when I talk about assisted dying, this is what I mean. Anything that doesn't fit into this description is not what I'm referring to. So, of course, in Canada, as many of you know, we use the term MAiD, or medical assistance in dying. We use this term for a number of reasons. The medical part, of course, is in reference to the fact that a healthcare practitioner is involved in this care in this country. MAiD is designed as an umbrella term in Canada because we do offer the options of either a self-administered assisted death, where someone will take a drink and control it themselves, or we have a clinician-administered assisted death, where the doctor or nurse practitioner administers the medication, usually through an intravenous line, and they're in charge. So both of these are legal and available in Canada. We are one of few countries that allow both choices, and the term that encompasses both is medical assistance in dying. You may be also aware that in Canada, the very vast majority of all assisted deaths have been done by clinician-administered procedure. This is by patient choice. And this is actually true in the countries in the world where there are a choice available, where there is a choice available. Well over 90 to 95% of cases are all done by the clinician. So I think that's kind of interesting. So I said we're going to do some foundational work first, and so that we can then get into some of the nuances that we're going to want to get into when we start talking about assisted dying and dementia. So how did we get here? This is actually, for me, I find this interesting. It's different than most places. In Canada, assisted dying did not become a reality because voters demanded it. And assisted dying did not become a reality because any government thought it was a good idea. That's just not how it happened. Both of these things can shift, with changing wind of politics. In Canada, actually, assisted dying is a rights-based issue, and it came about through constitutional court challenges. Assisted dying became possible in Canada because of our courts. And specifically because of this document. The Canadian Charter of Rights and Freedoms is a constitutional document in Canada. And because of the constitutional challenges based on these rights, that's how assisted dying happened. It's important to know that the court challenges that came forward to allow assisted dying were brought by people with both terminal illness and non-terminal illness. And that's important as this plays out. And the story is familiar to many of you, so I'll just very briefly say that back in 2011, two women and their families challenged what used to be, what I have very carefully drawn here, the big black box, what I used to call the big black box of the blanket prohibition of assisted dying in Canada that used to exist. It was simply criminal in all circumstances to assist someone to die. They felt that wasn't fair, and they challenged this. I'll save you the twists and turns, except to say that essentially what the court did is they carved out the circumstances under which the provision of an assisted death would no longer be considered a criminal act. And this became a decision that went all the way up to the Supreme Court of Canada. It was a unanimous decision in 2015. And these criteria, the blue box within the black box, so to speak, in my exceptional graphics, they lay out those considerations. And who is it that could have an assisted death and then it not be considered criminal? It was simply a competent and capable adult, so someone over 18 who has the capacity to make their own healthcare decisions, who was suffering intolerably from what was called a grievous and irremediable condition. That's as simple and as complicated as our Supreme Court decision was. You might note here that in this decision, there is no requirement that the patient be terminally ill or dying or near end of life. And that's an important, not omission, but an important thing about our law. And no particular restrictions were made. This court decision didn't say that if you have blue eyes, you can't have an assisted death. It did not say if you have a mental health disorder, you can't have an assisted death. And it did not say if you have dementia, you can't have an assisted death. It did say that you need these three things to be true. That's all it said. So that was 2015. It took the government some time, another year, to get a law in place based on that decision. And I'm going to save you all the political ups and downs and curvatures that happened in the next few years. They're interesting for the legal scholars. But let's just say in 2016, we had a law, a federal law, that regulated the delivery of assisted dying in this country. Then we practiced for 5 years. And in 2021, there was an amendment to the law based on that experience and based on some other court cases, and it brings us to where the law is today. So where are we today? Where are we now? Well, in brief, there are essentially 5 things that need to be true if somebody in this country wants an assisted death. I should say there's a process with it as well. Anybody who's interested in an assisted death in Canada needs to ask for it. Only they can ask for it. Nobody can trigger an assisted death for anyone else under any circumstances, no matter what is written in a lawyer's office, no matter whose healthcare representative you are, it doesn't matter. The patient themselves needs to ask for the request, and there's a way and a process that needs to unfold. They need to make a written request. It needs to be signed and witnessed and dated. I'm not going to go through all of those issues in detail. What most people want to know is who qualifies. So we have what we call eligibility criteria, and these are them, essentially. So I'm going to briefly go through them. Number 1, in order to have an assisted death, you need to be an adult. There's nobody who's 17 3/4 who can be found eligible. You have to be over 18 years of age. It may seem an arbitrary number, but this is what the law says. Number 2, a patient needs to be eligible for government-funded health services. So they don't necessarily have to be Canadian, but they have to be eligible for Canadian government-funded health care. So anybody with landed immigrant status, a refugee with status here, all Canadian citizens, Canadians who are living abroad, who come home, they are eligible for Canadian government-funded health services. The purpose of this eligibility criteria is that nobody else comes from another country, no tourists can come and pay privately. That is simply not legal in this country, and I don't expect it ever will be. Number 3, a patient needs to make what's considered a voluntary request. fairly self-explanatory. They can't be coerced into this decision. They can't be coerced blatantly by an angry spouse or a greedy child. They can't be coerced subtly by a clinician who throws their hands up and says, I got nothing else to treat you with. I don't know. I'm done. Like there are different forms of coercion, and it's part of my job to make sure that that's not happening and the patient makes a voluntary request. Number 4, the patient needs to have the ability to make their own healthcare decisions for themselves, meaning they have the capacity to make that request. Capacity and how to determine that is an entire lecture unto itself. I spend weekends talking to my colleagues about how we do this. I'm happy to get more into it with you later if you want, but I'm just going to say that capacity in medicine is task specific. So you don't have to be able to balance your checkbook. You don't need to necessarily be able to fly an airplane or to do other things like choose between complicated stocks you may wish to buy. What you do need to do is have the capacity to make this particular request, meaning you understand what's wrong with you, you understand what your treatment options are, you understand that palliative care is available, you appreciate the situation you're in, and can articulate an actual request for assisted dying given all that information. So the capacity to make this decision and to give informed consent. And then the final thing that needs to be true in order to be found eligible for an assisted death, you need to have what the law calls a grievous and irremediable condition. That took me some time to be able to say smoothly. A lot of people ask me what that means. We know what that means because it's defined in the Criminal Code of Canada. So in order to have a grievous and irremediable condition, 3 other things need to be true, and they need to be true at the same time, and we need to document them as true. So what are they? The person who's asking for an assisted death needs to have what we call a serious and incurable illness, disease, or disability. And each of those words are important. They need to already be in an advanced state of decline, meaning a decline in function. The law says decline in capability, but this means function. They're no longer functioning the way that they were before they had this serious and incurable illness. And that bar of whether they're in a little bit of decline or an advanced state of decline is determined based on who they were and how they were functioning before they were ill. So it might be different for one person than another, a professional athlete versus someone who sits at a computer all day. Their level of function may be different than another person's. And then the third thing that needs to be true for a grievous and irremediable condition is that the person is enduring a suffering that they believe is intolerable and that cannot be relieved by anything they find acceptable. So all of this needs to be true in order to be found eligible for an assisted death. It's not so simple. It's quite a robust system. What I want to mention here, there's a little red asterisk under the first issue for grievous and irremediable condition. Our current law since 2021 does explicitly exclude people who have a mental illness, is the term they use. What they mean is a mental health disorder. If that is their only issue, there's no other illness involved in the request for MAiD, then they are not eligible to access MAiD in this country at this time. And that is an exclusion that was put in 2021. What's important to understand, though, is that dementia and other neurodegenerative disorders are not included in that definition of a mental illness. It's explicitly stated in our law, so that is not within the exclusion. So those are the eligibility criteria in probably more depth than I meant to give you. Now, if you meet all these criteria, you may have an assisted death, you may become eligible, but how you actually access the assisted death depends. In fact, on top of eligibility criteria, we also have what we call procedural safeguards that must be satisfied before you can move forward. And since 2021, there are actually 2 pathways, 2 different sets of safeguards. You'll either have to follow track 1, or as we cleverly call it, track 2. So, I would just say track 1 is the more straightforward pathway. There are fewer safeguards. They are the ones that you are probably thinking of that I mentioned earlier. There's a written request. That request is signed and dated and witnessed. those kinds of safeguards. Track 2, you have to meet all the same Track 1 safeguards, but there are more of them. There are more robust safeguards. The question, of course, then becomes, how do you decide which track you're on? Do I do Track 1 or do I do Track 2? And the clinician helps to determine which that is. The decision about which track you're on is determined by whether or not your natural death is reasonably foreseeable or not. Another weekend conference, we could talk about what reasonably foreseeable actually means. We spent a couple of years trying to understand that. But essentially, what that means is that your death is predictable due to your illness, and that it doesn't have to be happening in a certain period of time. It's not in 6 months or 12 months or 2 years. It's that you're on a trajectory towards death due to your illness, and it's relatively predictable in a reasonably foreseeable amount of time. So maybe not the clearest definition, but that's what decides. If your death is reasonably foreseeable, you go down Track 1. If your death is not reasonably foreseeable, you go down Track 2. What kinds of examples? Track 1, reasonably foreseeable death. What we're typically talking about is someone with a cancer diagnosis, might already be metastatic, widely distributed. They're expected to have a prognosis of a relatively short period of time. These are clear-cut Track 1 case. Track 2 tends to be people with more chronic illness, could be a chronic pain illness, could be a very, very slow neurological condition, or some illnesses that we know less about. So I did mention some of the Track 1 safeguards. Again, I'm not going to go into these in detail. I do want to point out a few things. Let me say that in the Track 1 safeguard, we talked about some of these issues already. One of the other safeguards that must be met for Track 1 patients is that they give their actual explicit request to have an assisted death, not just when they make their written request on the form in the province, but also at the time of the death itself. That's mandatory for Track 1 patients. There are 2 exceptions we're going to talk about later. Track 2 patients have to meet all of the Track 1 patients, as I mentioned, but they do have these extra safeguards. And in general, they are things like a mandatory amount of time for the assessment, a minimum of 90 days. There's mandatory that someone who has expertise in the condition that's causing the suffering is involved in the assessment, that patients are offered, become aware of, and are offered the reasonably available resources to help reduce their suffering, that they're aware of those resources, that they've been offered those resources, and that they've given what we call serious consideration to trying them. So a very robust system. And essentially, this is the end of what I call the foundational section. That was MAiD 101, the foundations of how MAiD works in Canada. I'm hoping you're all still with me. I can't see your faces. What I'd like to do now is shift to what I call the graduate course, which is about MAiD and dementia. And it is a little bit more complicated, so we're going to build on the foundations that we've just reviewed. So is it possible? Can patients with a diagnosis of dementia access MAiD in Canada? And I gave you the spoiler alert that's yes. So let me tell you why I say that. As I've just explained, under the Supreme Court decision, dementia was not excluded from assisted dying. So patients with MAiD were not ever told at any time in the Supreme Court decision that they couldn't have MAiD. And in fact, the very first law, which we call Bill C-14, and it was written also, did not exclude anyone from assisted dying. So what was in the past, dementia was not excluded. What is currently? Well, we know that the current law excludes mental health disorders, but it doesn't exclude dementia. So that is not an issue either. And as it's not a mental issue, it's not excluded under our current law. The question is, how can that maybe happen? Because the tension, of course, is in meeting all of the criteria. And as I've just gone through the criteria with you, you can see that it might be challenging to both retain the capacity to make your own healthcare decisions and at the same time be in what the law requires, an advanced state of decline. Usually with illnesses that affect our cognition, by the time we're in an advanced state of decline due to that cognition, our capacity to make our healthcare decisions has been challenged. So how can both be true at the same time? Because if they can't be true at the same time, this can't happen. So how can that happen? Well, I want to tell you just very briefly about a model of care, an approach to care that we take, that we borrowed from our colleagues in the Netherlands, where they do this work as well. Their system is very similar to ours. The way that their law works is very similar to ours, and it's a model of care that we call 10 minutes to midnight. I should preface this by saying not every MAiD practitioner in the country is comfortable with this approach. This is an approach that I use, that many of my colleagues use. I would say that most experienced colleagues in MAiD practitioners will use, but not everyone. There is that to keep in mind. The point I want to make is, though, despite a lot of controversy about assisted dying, not everyone agrees with the idea of assisted dying in general, but one thing I think that we can all agree upon is that if someone is no longer able to make their own healthcare decisions for themselves and about themselves, I think we can all agree that at that point they are in an advanced state of decline. I don't think anybody would argue with that statement. So with that in mind, this model suggests that if I meet somebody early enough on in their disease where they have a diagnosis, they've already shown some symptoms, they're struggling a bit, but they are doing everything they can to maximize their function, and they're aware of this idea of assisted dying. They think maybe they want to learn more about it, or maybe come talk to someone about it, or possibly consider having an assisted death one day in the future. They come and see me, and I get to know them, and I get to speak to them, and I get to hear about their life and what's important to them, and what their values are, and why they might consider an assisted death, and they can explain themselves to me. I can document all that and follow them along. Might be every 6 months at first, might become every 3 months as they become a little bit more ill. And I'm always documenting the changes I see and checking in with them about what they really want and what's really important. And the model goes that at some point, if midnight represents not where you turn into a pumpkin, but midnight is where, after which, you lose the ability to make your own healthcare decisions, so you're in an advanced state of decline. If that's what happens at the stroke of midnight, then this model of care suggests that I can see people around the face of the clock at 2 o'clock, at 4 o'clock, at 6 o'clock, at 9 o'clock. When they get to 10 minutes to midnight, when you're getting close to that stage, I might be able to have a conversation that says, Mr. Smith, I've known you for a year and a half now. We've talked a lot about what's important to you. You've always said to me that if you're unable to make your own healthcare decisions, that would not be acceptable to you. You would rather have some help to end your life than to live through the final decline of dementia. Is that something you want to talk about today? And at that point in time, I believe that Mr. Smith still has capacity to make that decision for himself because he's not yet at midnight. And at the same time, it is imminently happening, probably in the next 2 to 3 months, in my best medical guess. Mr. Smith, I think in the next 3 to 4 months, you will probably lose the opportunity to make your own healthcare decisions. So in those last 10 minutes, I think that you could easily argue that Mr. Smith has both the capacity to make this decision and is already in an advanced state of decline. So I think it's a very small window, but I think it's possible. We've certainly done this before. I've certainly helped people in this type of model of care. And I want to emphasize that in doing this approach, Mr. Smith is making the decision himself, for himself, under his own ability to make that decision. The capacity is still present. This is nobody else triggering this for Mr. Smith. So that's generally how this works, but this is not quite as straightforward as I maybe made it sound, because as many of you will be aware, as cognitive challenge increases over time, many people in that situation will lose some insight into what's happening to them. They may not be as aware of their losses, their functional losses. They may not mind anymore that they can't use the remote on their television, whereas before, 6 months ago, it was incredibly frustrating. So if Mr. Smith gets to 10 minutes to midnight and has lost his insight into his illness or has lost his sense of suffering because of his illness, what I'll hear is, oh yeah, I want that assisted death one day, but not now. I'm doing fine. I'll be in touch. And then often he'll pass midnight and lose that opportunity. So this can be a complicated assessment, but it is one that's possible. So I think I'm hoping that's clear enough that I can go on. For those of you who are interested in how this might work, a better example, a little bit more detail. I had a patient who went public with his story. His name is Gail Garlock. This is him and his wife, Barbara. They made a CBC radio documentary a few years back, or she did after his passing. And it's very nicely outlined there how the 10 minutes to midnight model works. And it's about just under a 30-minute radio spot that you can listen to. At this point, I'm probably babbling too much. I'm going to keep going. I do want to take a moment to just define just a few terms before I keep galloping further. Many of you will know what an advance directive is. It's an umbrella term that refers to a person's wishes with respect to their health care and their personal care that they can make before they lose their capacity to make a decision. So I might write down on a piece of paper in my lawyer's office, if I get hit by a bus and end up in the hospital on a ventilator that's breathing for me, if it's been 60 days and there's no sign of my coming off the ventilator, I would like you to take the ventilator out and allow me to die. That's me speaking for myself in advance, giving my own directive. These tend to be called living wills in the days gone by. They're actually technically called advance directives in British Columbia, and they allow you to speak for yourself. This is a lovely idea, and I encourage people to make advance directives, but this is not what I'm going to be talking about today. That's an advance directive. An advance request for MAiD, for an assisted death, is a request that's made before you are eligible, before you're fully eligible for care, before all of those criteria that I mentioned have been met. And that might be someone with a cognitive challenge, with a mild cognitive challenge, or even an Alzheimer's diagnosis or any diagnosis of a dementing disorder that might say, I know what's coming. I've seen this in my family members. When A and B and C become true, I would like to have an assisted death. I'd like to make an advance request for MAiD. This is something that we hear a lot from Canadians that they want. I want to be super clear that this is not currently legal in Canada. We're going to come back and talk more about advance requests in a moment, but before I do, I want to talk about one other definition, which is an advance consent. And I'm sorry that this is confusing. It took me a while to figure it out myself. But an advance consent is not a request. It is someone giving consent for a procedure, could be an assisted death, before they lose the ability to make the decision to do so. And I think this is best explained with an example. So an advance consent. Some of you may be aware of the story of Audrey Parker. This was a woman in her late 50s who was in Nova Scotia. She was given a diagnosis of metastatic cancer. There was only so much treatment she could have before her disease overtook her. She knew that she was dying. She wanted an assisted death. She applied for an assisted death. She was found eligible for an assisted death. And she was making plans for when that would happen. She very much loved the Christmas season. This was in the late summer, early fall. She wanted to plan for her death in January and then live through an extra Christmas season and then have her death in January. And she was eligible for that care, and that was the plan. But in the fall, she was told her disease had progressed to the lining of her brain and that she was likely to lose her capacity to make this decision before January. So she was faced with this decision. She was told by the doctor, you either have to act now when you can give us consent, so maybe earlier than you'd like to, or you don't have to go ahead now. You could go through Christmas and see how that goes, but if you lose capacity, then in January, we won't be able to give you an assisted death. We'll have you supported with comfort. You'll have lots of palliative care. You won't have an assisted death though. And she thought that was ridiculous. She thought, here I am, I'm fully assessed, I'm fully eligible. I'd like to consent now, give an advance consent for my death in January, even if I lose capacity, but the law did not provide for that. And Audrey Parker decided to keep control, and she decided to die earlier and had an assisted death in November. But her family and her friends carried on with her advocacy for this work. And in fact, in 2021, when our law changed, there was the stipulation to do exactly what she was hoping for. And this is one of the exceptions that I referred to earlier on the track 1 safeguards. If your death is reasonably foreseeable, think of Audrey Parker, you have made a written, signed, and dated request and met all these criteria, you can give consent in advance if you're already found fully eligible for MAiD. So this is one of the exceptions to the final consent that was required under the safeguards. It's called a waiver of final consent. It's only available for track 1 patients. The patient must be someone like Audrey who's at risk of losing capacity to make their own healthcare decisions. They have to have already set a date for their assisted death. You can't just say at some point in the future. There's actually a plan. I'd like it to be on January 4th. This is what I want. And most importantly, the patient needs to be found fully eligible for MAiD, all the criteria that I listed, before they lose their ability to make this decision, before they lose the capacity to make this decision. So this is not an advance request for MAiD. This is a very special mechanism, a tool, a type of advance request that's only available for patients who meet all of these criteria. And if you're ever trying to figure it out, just think of Audrey Parker and it should help make more sense. I hope that's relatively clear. So I say all that story because our current law does not exclude patients with dementia from having an assisted death. And the question is, are they eligible for a waiver of final consent? At 10 minutes to midnight, could Mr. Smith have a few choices? He could do nothing and continue living with his illness, having lots of support and having, many years perhaps left in his life. Could he decide to go ahead with an assisted death under his own capacity at 10 minutes to midnight? Or could he sign a waiver of consent saying, I'd like to have an assisted death in 30 days from now or 60 days from now, and if I lose capacity between now and then, I'm covered by this waiver that allows me to go ahead? Well, the answer is technically he could sign a waiver. So in theory, Mr. Smith could live every moment of his life while he still has capacity, and when he gets to that new place where he passes midnight, then the doctor could come in with this waiver and have his assisted death. I just want to say that this is very complicated for patients, their families, and for practitioners. Yes, it is legal. Yes, we do it. But do I think the law meant a waiver to be used in this situation? No, I don't. I think it was meant for patients like Audrey Parker that were much more straightforward. I'm not sure it ever contemplated being used in patients with decreased cognitive ability, but it is possible. It's clearly not the best answer. The big question is, what's coming in the future? Is there the possibility of an advance request for MAiD where someone could say, when A and B and C are true, I would like to have an assisted death. I'm going to write it down now, give my advance request, give my advance consent, and hope that that will happen. We know that Canadians want that. So the question is that going to be possible? So let's see where we might be going. Well, interestingly, the province of Quebec has passed provincial legislation that allows exactly that, to allow an advance request for MAiD. They passed that law in June of 2023. They've been talking about it ever since, and in fact, this fall, they are implementing this possibility as of October the 30th. This will become a legal possibility in the province of Quebec. That does not mean it's going to be legal anywhere else. And I should say it's still very complicated because although the province of Quebec will make this legal, we have a federal law, the Criminal Code of Canada, which still says it's illegal to do so. So we have a discrepancy in a federal law and a provincial law. The province of Quebec, their prosecutors have issued a report saying that they do not believe it's in the public's best interest for any doctor who follows the provincial law to be prosecuted. So they should be clear and able to do this work, but we'll see in the month of November if this actually goes forward. I expect there will be one or two brave souls who probably go forward with this. Probably will take a long time to know how this works because people will start setting up advance requests for MAiD, but it may be months or years before they want to invoke them. But I assure you the rest of the country will be looking carefully at what happens in Quebec. This may put pressure on the federal government to harmonize this across the country. We may see some movement, but just to make it complicated, of course, we also sense there's going to be a federal election somewhere in the next year or so, and I'm not sure that the next government of this country will be in favor of such a move, so it could be some time yet. I guess what I would say if I was looking in the crystal ball, I think advance requests are coming to Canada. I don't think it's in the next 5 years, in my opinion. I do think it will be in Quebec as of the end of this month. So that's a lot of information. I'm hoping you're not too confused. I just want to say in summary, I think that assisted dying came about in Canada from a rights-based constitutional court challenge. So this is a court-driven change. There is a rigorous process in place. There are rigorous eligibility criteria. There are rigorous safeguards that are in place. This is not a simple matter. You don't just call my office and ask for an assisted death. MAiD for dementia patients is possible. It is not excluded in our law, but it is complicated. We do have a model to approach this care. It's the 10 minutes to midnight model, and it works. And we've been doing that since 2017, so we have good experience, but it's not simple, and it won't work for all patients. Some patients will simply not be able to do that. A waiver of final consent is a possibility now in our country. It is possible for patients with dementia to sign waivers of final consent at 10 minutes to midnight, so they don't have to make that decision before they lose capacity, but it's very, very complicated and doesn't work, again, for all patients. Quebec is, of course, moving ahead with advanced requests for MAiD, and we'll see where that moves to the rest of the country. I have a number of resources up here. I think they're in your handout that the Alzheimer's Society has put together for you already. There's also some supports for families and loved ones. If you're not aware of those, it's probably also in your resource list. But just to highlight, the MAiD Family Support Society, based here in British Columbia, is an online group that supports people going through this process. And Bridge C14 is another national group that's based out of Ottawa, that does the same type of work to support families, patients, families, and their loved ones who are going through the assisted dying process. There are certainly advocacy groups in this country. There's certainly groups for clinician support, the Canadian Association of MAiD Assessors and Providers, of course. And I think I'm going to stop talking so we can get to some of your questions and see where I was and wasn't so clear. So thank you for your attention.
Okay, thank you, Dr. Green. That was incredibly informative. We do have some great questions that have been coming in throughout the presentation.
Great.
So I've tried to group them together a little bit. We did have two questions regarding the mental illness clause that you mentioned at the beginning.
Yeah.
Is there going to be a change to this law so that people living with a mental illness can access MAiD?
So it's a great question. I guess what I didn't emphasize, and I should say, patients who have mental health disorders, who also have concomitant, who also have physical health disorders, can apply for MAiD and have received MAiD, based on their physical illness. Somebody with bipolar disease can get pancreatic cancer, and they can apply for MAiD due to their pancreatic cancer, as long as their mental health disorder is not interfering with their ability to understand what's happening and for them to be able to give consent. That's not an issue. So, I mean, there's a large number of people in our society that have, that deal with mental health disorders. It's not rare. So we do see patients with mental health disorders. They do access MAiD. If it is the sole underlying condition with no other physical illness, they are currently excluded. That exclusion was supposed to automatically sunset out of our law and allow these patients access in March of 2023. That was extended to March of 2024 and has now been extended to March of 2027. Most of us who work in this field feel that punting of that to 2027 meant that this government is not interested in that subject, is not interested in changing that exclusion, and likely the next government has already campaigned on the fact that they will shut that down and not allow it to happen. I think it's not coming soon. I can tell you, though, that what's happened because of that, because that is, I'll just show my true colors. I mean, whether you like it or not, that is blatantly discriminatory based on a diagnosis. I'm not saying it would be easy or it's a good idea, but to exclude an entire category of patients from accessing MAiD due to their diagnosis is never going to, survive a charter challenge. What's happened is there is, in fact, launched less than 3 months ago, a charter challenge based on this issue, and that is now going through the courts. It's based in Ontario. It'll probably take a couple of years to move through the courts. I expect it will get to the Supreme Court, and we'll finally have an answer in this country. But it might take 3 to 5 years to get that.
Thank you. And I think you answered another question that came in. Someone was worried that they may not be eligible because they have a chronic pain disorder along with a mental health disorder that they've been living stably with for over 40 years. So in that case, they would
They
potentially
could.
be eligible.
Yep, they could be eligible based on the chronic other illness.
Okay, thank you. There's quite a few questions regarding the 10 minutes to midnight approach,
Yeah.
specifically around who can, I guess, follow that approach. Can people have this conversation with any family doctor, or is it only MAiD practitioners that would be aware and use this approach?
So this approach is used by MAiD practitioners in order to help us assess people who have a dementia diagnosis, who are hoping to have and express their desires to have an assisted death. A GP, a family doc, anybody could follow along. I mean, obviously, there's a team of people caring for these families, and they need to continue to, and they will all be documenting what's happening, who's thinking what they're expressing, and that's all very valuable record keeping that is used by the MAiD assessor. I personally, and I think most of the MAiD providers that do this work, if I'm seeing someone with dementia, I will follow them personally as well. They will continue to see their geriatrician or neurologist or GP or whoever is taking care of them. I don't presume to handle their primary care or do their medications, but I do want to see them on a regular basis to see what's happening as we move around the clock face. So this is really a tool that's only known by and used by the MAiD practitioners. I mean, anybody could learn it, but it would only be able to be implemented by a MAiD practitioner who has to be an MD or a nurse practitioner.
Okay, thank you. And there's a related question around whether or not this approach is sort of standard for MAiD practitioners across Canada.
So it's known to MAiD practitioners across Canada. It is not accepted by every MAiD practitioner. Some practitioners simply will limit what kinds of patients they'll see. There are MAiD practitioners who won't see a track 2 patient. There are MAiD patients who won't see dementia patients. There are MAiD practitioners who won't see people with leukemia because it reminds them of their great Aunt Mabel who had leukemia. So any MAiD practitioner can limit their own practice, but those who do take on patients with dementia are generally quite aware of this. Our organization, the one that I helped co-found, the Canadian Association of MAiD Assessors and Providers, we have guidance documents on how to assess patients with dementia for MAiD, and we also have in that the 10 minute to midnight model is mentioned in there. We do teaching. We have national curriculum where we teach practitioners how to do this work. We talk about the 10 minutes to midnight model there, so it's out there for those who are looking for it.
Thank you. A question around the waiver of final consent. In this scenario, an individual does have that in place. The family member is worried that they may lose capacity to make that decision. Can a family member who has power of attorney and the ability to make health-related decisions on someone's behalf provide that consent?
Yeah, so two clear answers. First of all, nobody can give consent to MAiD on behalf of another patient. No power of attorney, no healthcare representation. Nobody can do that. What's interesting about the waiver of final consent, it's that nuance. It's important to understand is it's the patient who's asked for the waiver. It's the patient who set the date and given consent themselves for that date to have assisted death. And what the waiver says is, I'm planning to go ahead on Friday at 3. If the tumor in my head bleeds and I'm no longer able to speak to you or communicate my decision, this waiver says that Thursday at 3 you can go ahead and it's not a crime. That's because I've given you consent as the patient. It's my consent, not because my spouse said this is what he wanted. The patient themselves is giving the consent in the waiver. So theoretically, the doctor holds a little waiver in their pocket, and at Thursday at 3, you still go in and ask the patient for their own consent. And if they can consent, you never use the waiver. Patient consents at Thursday at 3. But if the patient is all of a sudden unable to consent, I whip out the waiver and say, they told me at Thursday at 3, this is what they wanted. I see they don't have capacity anymore. This is what I promised to do. I'm going to go ahead. In fact, without trying to be controversial, I don't need the permission of the spouse standing next to them because I already have consent. If the spouse is agreeable, that's going to be helpful. If the spouse is not agreeable and has decided for some reason to change their mind, I'm legally still able to go ahead. That would be a little bit silly of me in the face of that controversy, but it's the patient who's given the consent. And if they've lost that capability, that is the exact purpose of the waiver, to speak on their behalf for themselves.
And they can have MAiD happen before that date on the waiver, is that
They
correct?
can have MAiD happen before the date, before Thursday at 3, if they've already lost capacity, and if so the waiver actually says on or before that date if
Okay,
capacity is lost, and both the assessors, there's two assessors that need to be involved in every case, two doctors or nurse practitioners. If both agree capacity is lost, then you can move ahead and you can and go ahead sooner.
thank you.
Yeah. You can't
Um,
pass the date though. If MAID is not provided by Thursday at 3, by the date on the waiver, and capacity is missing, once you pass that date, there's no more consent. That's your final
okay.
date.
But if the person is still able to have capability to consent, they can extend the waiver, is that
They could
correct?
theoretically enter a new waiver for a new date. The law
Okay,
doesn't say there's a limit on how many times you can do that. They don't say there's a limit on the date that you set. But I can tell you that in practice, it's become a bit complicated because, well, I mean, let me just put it to you. Basically, if I have a waiver and someone has recently lost capacity, it's been a little bit dicey, and all of a sudden it seems very clear they can't. In our minds, it seems very clear we have this piece of paper, we can go ahead. But let me tell you what it's like from my point of view. There might be someone I followed for 18 months. I've gotten to know them. I know exactly what they want. We get to 10 minutes to midnight. They sign a waiver and say, you know what? I want to live out every single last minute. I'm going to set my waiver at 90 days from now. And by then, if I'm a little confused, you can go ahead. So 90 days roll around, and sure enough, Mr. Smith is no longer capable. But that doesn't mean he's had a radical change. Might be living in a facility with good care. Might be in that stage of illness where very functional, goes to goes to music therapy, does chair physio, still participating, has no idea who his family is, unfortunately. Right? Has lost certain functions, but still maintains others in that middle phase. We're not the early phase and not that really advanced phase. It's not so easy for me to go in then to see Mr. Smith, who then says to me, you look familiar, but I don't know who you are. I said, yeah, I'm Dr. Green. I'm here to help you. We've known each other for a few years. I'm here to help you. Oh, that's nice of you. I'm about to go to my exercise class though. Can we talk later? Well, no, actually, you asked me to come and help you. I'm going to give you some medicine. Like, I'm not going to strap his arm down and give him
yeah,
medicine to end his life in a situation where he's, unaware of what's happened. So it's very complicated. It's not so easy to use a waiver, is my point.
thank you for providing more context around that. There's a few questions. I'm not sure that this one can be easily answered, but there's a question around how long the process takes, I guess, from the time a request is made. Um,
Yeah, so it is really a case by case decision. So I've been doing this for a very long time and I do a lot of MAiD, so I'm going to be an extreme, but I have provided MAiD to someone on the same day that I met them. There are some urgent situations where sometimes it happens that that is possible. It's very uncommon. It's very unusual and it's not something we ever want, but it is theoretically possible. And I have seen patients, I think the longest one I'm carrying right now is about 3.5 years. So it really depends on the illness, depends on the path of the illness. With patients with dementia, I like to get to know them over time so I can see that change and really understand what they want. I find serial visits over time is the most effective way to do this, but it can be done shorter if there's urgencies. And I mean, it can be days, weeks, months, or years. It really depends.
thank you. There's a few questions as well around accessing a MAiD practitioner. Can you maybe give your advice on what would be somebody's first step if they're interested in
Yeah, for those
accessing
of
a
us
MAiD
lucky to
practitioner?
have GPs or family doctors, it's always ideal to go to your primary care clinician and discuss the fact that this is something you're hoping to discuss. I would say in British Columbia, a majority of primary care physicians are open to the discussion. Not all are well versed on it, and some are certainly not open to it, but that would be the starting place if you can. More Perhaps more helpfully, you don't need a referral from a doctor. You can self-refer. So in British Columbia, every health authority has a MAiD coordination office. So if you're in Island Health, you call up or Google assisted dying Island Health. There's a website, a fax number, an email, a telephone number. You call the coordination office and say, I'm looking for information on assisted dying, or I'm looking for a doctor who could help me, and they will help educate about what the process is and how to find an assessor. There are in some places waiting lists to do that, in other places not waiting lists. Every community is a little bit different. There's no public listing of the people. The easiest way to access an assessor or a practitioner is through the local MAiD office. I personally happen to have a website, but most MAiD practitioners don't.
And I will mention that we do have those offices linked on the helpful resource document that
Great.
Ashton has put in the chat. Is there a cost associated with accessing support from a MAiD practitioner?
That's an easy one. There is zero cost. It is a covered legal medical service. Just like if you go to get your blood pressure taken, there's no cost to you. MAiD assessments and provision are free of charge for the patient and family.
Thank you. I think you've touched on this a little bit, but not all MDs or nurse practitioners are likely willing to offer MAiD or able to offer MAiD. Is that correct in your?
Yeah, I think that's accurate. I mean, there are something like 90,000 doctors in this country. There on the last annual report, there were, I think, 1,600 individual clinicians who had provided MAiD, and the vast majority of them had done, one or two. There's a small number, a few hundred doctors and nurse practitioners that do the majority of assisted dying in this country. There's clearly not enough clinicians for the increase in demand.
Thank you. And there's a question around access again, specifically across Canada. I imagine there might be parts of Canada that there isn't a lot of practitioners available and access might be limited.
Yeah, so it is a federal law. It is legal. It's with the same eligibility criteria and safeguards in every single inch of this country. As many you know, healthcare is actually delivered provincially. So how it's rolled out and administered is different province to province. At this point, we actually have practitioners in every province and territory. There's been a real effort to try to do that. There are definitely communities where there are none or where there are very few, and there are other communities where there are plenty. So there is a diversity. In British Columbia, I mentioned there's a MAiD office in every health authority region. That is not the case in every province. There are provincial coordination systems in some places like Ontario. It's kind of set up differently, but there are practitioners in every province and in most communities at this point, but not all.
Okay,
And
thank
we
you.
can use telehealth now if we need extra supports from each other. So there may be a community where there's only one clinician doing the work, but you need two clinicians to do the assessment. We can now use telehealth and video when it's necessary, and that's really helped the access for remote and rural communities like we have in BC, like in Northern Ontario. That's been a huge help.
Mm, absolutely.
Yeah.
Okay, I think there's just one question left around how early somebody should start that conversation with a MAiD practitioner. In this example, the person is saying they've been diagnosed at 61 and are in the very early stages of dementia.
It probably depends on the community, to be honest. The community I work in, we're relatively well serviced, and there's several of us that do patients with dementia. And so I think the ideal is that you make a connection relatively early on after diagnosis. The more you're able to explain why you want to explore this and why it's important to you, the better you can explain it, the better. Because then, even if it's not, even if you're only checking in once a year, it gives the clinician a real good chance to understand who you are and what you want. There are other communities where there are not so many clinicians that do this work and very few who take dementia patients, and the burden may be simply that they don't want to see you early on. I think the question is to call the best thing is to call the MAiD coordination service, explain that you're interested in having this conversation, and do they advise you to seek out an assessment now, or let them help triage that based on their own community.
Okay.
Yeah.
And we just had one more question come in. Do you see one MAiD practitioner generally, and they document your case, and then when you have this second assessment, does that practitioner, I guess, what is involved with that assessment? Do they go by the first practitioner's notes, or are they, how actively
No, yeah, that's a
involved
good
are they?
question. The assessments need to be independent of each other. So
Okay.
so each assessment, each assessor, each practitioner has to do the work to decide whether they believe that the patient in front of them is eligible. They can share the same records, the hospital records, the specialist records. They can speak to each other if there's, I have this information. Did you want? I can send you the consult note that you haven't seen. They can even read each other's notes, but the assessments are meant to be, they need to be by law independent of each other, so that it's a safeguard to make sure it's not just one person's opinion. You need to have two healthcare practitioners who both agree that the conditions have all been met. And sometimes that means more work for the patients and families, double the visits, extra time. But this is not meant to be a simple process, and it's not a simple process. So if it takes that, then that's what it takes.
Yeah. It sounds like there is sufficient safeguards in place and that it's something
I think so.
you act in, quite seriously.
Yeah.
There is a question around how often assessments are done over the phone where the assessor doesn't see the patient. You mentioned telehealth is available. I imagine that would involve video conferencing sometimes.
Yeah. So there are professional standards from the local college. So like the College of Physicians and Surgeons of British Columbia, the people who give me my license, they have standards around how to do MAiD work that I need to comply with, even if they're more stringent than the federal law. They do allow telehealth. They are not keen on telephone visits for things like this. This is not really a best practice. It would be frowned upon to do an entire assessment by telephone. I'm not even sure that would be allowed.
Okay.
So telehealth visits are allowed when it's really not possible to do in-person assessments. And most of the time we can do telehealth for many stories. But I have to tell you personally, when I am seeing patients that I'm just getting to know, or if they are patients with cognitive challenges, I find telehealth far less superior than an in-person visit. So I would never rely, I would try hard not to rely on them. It would be unusual that it would be a case, an entire case where all of the assessments have been done on telehealth. That would not be, and it's certainly not by telephone.
So it would be more of the exception if it was done. It's not
Absolutely an
the
exception to the
go-to.
rule. I mean, someone you've been following for 3 years and you happen to have one of your follow-up visits by telephone, that's certainly fine. But if you're only going to see someone two or three times and it's always on the telephone, that's not going to be okay. There's an oversight body that will look at these cases and probably not find that acceptable.
Okay. I guess how comfortable are you continuing to ask questions?
Oh,
There's a
I'm
few
good.
that are
I'm all
coming. You're
yours.
good? Okay.
Yeah.
There's one more that came in around, I guess the frequency in which you should be connecting with your MAiD practitioner. They have commented that it sounds like you have quite a relationship with your patients in this situation. They've qualified for MAiD. The practitioner hasn't been in touch recently since they qualified a few months ago. And so, should they reach out? What type of relationship can they maybe expect from a MAiD practitioner?
Yeah, I mean, I think again, I can't speak for everyone. I know what I'm comfortable with. But there are communities where there are very few clinicians and where they just simply don't have the ability to have constant contact or have regular contact as much as they might like. So I think best practice would be regular follow-up with someone. But there are practitioners who believe pretty strongly that if they found someone eligible, it's not for them to be contacting every 3 months to say, "Hey, how you doing? Are you ready?" It's not really, that's not our job. It's up to the patient to say, "You know what? I'm feeling like I might be ready. I'm going to reach out." And that way it's the patient who's asking, who's making that effort. I think in every individual case, because every clinician is different and every case is different and every unfolding of illness is unpredictably different, I think what's most important is that it's clear what the follow-up plan is. So at the end of every visit, it's clear who's calling who or if anyone's calling anyone. Can I expect your call in 6 months? Should I call you in 6 months? Will you be calling me in 6 months? Do I not call you until I feel like I'm ready? The answer to that question should be decided at the end of every visit, and that's how you'd go forward. So it's impossible to say what in every situation what should happen. Best practice is some sort of regular follow-up, but it's not always possible.
Okay, that makes sense. So, I mean, it doesn't hurt probably to reach out if it's been a few months, and
If it's
especially if things are
unclear,
changing. Yeah,
yeah, and
and you're
especially
not sure.
if it's unclear what the plan is for follow-up, maybe
Yeah.
just clarifying, are you waiting for me to contact you or will you be contacting me? I was just trying to clarify what our follow-up plan is.
Perfect. Thank you. Um, oh, we've gotten quite a few more
And I
questions.
should say, sometimes the Care Coordination Center can play that role and do the follow-up for clinicians who maybe don't have as much time. So again, it really depends on the community. Excuse me.
Okay. Um, so this question is around the legality of, I guess, um, assisting MAiD on a family member. So I don't know how actively involved family typically are. I know there is one option where someone can administer the drug themselves. Can a family member, I guess, assist in that process?
Is that the question? With can family members assist in the process? Interesting.
Well, are there
Um,
legalities about doing MAiD on a family member?
as opposed to me helping someone I'm related to. Yeah,
I'm not sure.
so the only people who are allowed to assess and provide MAiD in this country legally and not be charged with homicide are medical doctors or nurse practitioners. Anybody else who says they can do an assessment or tries to do an assessment or provide MAiD is breaking the law.
Okay.
That's the first thing. One of the ways to receive MAiD is a self-administered medication.
Mm-hmm.
And in the province of British Columbia, the standard by the college that licenses me says that I must be present when that happens.
Okay.
So I would pick up the medication, bring it to the patient. Patient holds the drink, drinks it themselves while I'm standing by to make sure it's going to work. Is the question, can the family member hold the glass? I don't think that that's illegal. It has to be the patient who says, or like not everybody has a hand, right? So could somebody hold the glass, put a straw in their mouth? Sure, it has to be the patient who's saying, this is what I want. I know what I'm doing. I understand what's going to happen, and I want to do it on my own. And if I need you to put the straw in the cup for me, that can happen.
Okay.
But
So it's always something that you would be there monitoring as well. It wouldn't be
absolutely,
something that the family would do on their own. Okay.
absolutely, yeah. In this province, that is true. There are provinces where you don't have to be present, but yeah.
Okay. Thank you. I hope that answered the question. Um, with an election likely to take place federally, what can we do to encourage the current government to allow for advance requests?
It's the million-dollar question for the advocates. I can only tell you what I think with my political thoughts. I think it's probably too late for this administration to do much. I think what you could do, I think the only thing that could happen is that it is clear in national polls year after year after year that a large majority of Canadians want advance requests for MAiD. I think you can make it an election issue. I think you can take a government that's possibly not going to do so great in the next election and somehow convince them and their advisors that this is an election issue that they could gain support for. If they realize that 80% of Canadians would like this to happen and they make it a platform on which they campaign, they might do better because all they're thinking about is how to get elected, right? At this point in their mandate, they're not looking to just do good. That's not the issue. And as I think they're probably struggling, I think the best thing you can do if you're advocating for that is to make it a campaign issue.
Okay. Thank you. I think there's a little bit further clarity on that question involving the family members that's come
Great.
in. I believe it was someone who has a family member who is a doctor. Can that family member who is a doctor, I guess legally
Provide MAiD.
provide MAiD?
So it's not so much legal, it's more about a professional obligation. So legally they're an MD, so in theory they could, but for the same reason that I'm not supposed to provide medical care to my family if they've got a urinary tract infection or a pneumonia, I'm not supposed to write the prescription for them, certainly not for their codeine, for their cough. That's frowned
Mm.
upon by the college. So I would say that I've never seen it actually tested. Let me just think for a second. I am not aware of a case of a close family member. I'm not even sure of a distant family member. I'm not aware of a case in Canada where it's happened that someone who's related to the person who's receiving MAiD has been providing. I think most of us would step away from that. I can't think of a practitioner who would say, I would provide this on a close family member. They would just, their license would be in jeopardy for the same reason of any other medical care, for the same reason, not because it's MAiD. It
I'm
could always
sure, of
be questioned, right? I mean, someone could always say,
course.
That's cry foul.
And I'm
Coercion.
sure there's other ways that that family member can be present and
Yes, and be
involved, but
helpful.
yeah.
Yeah, and try to smooth the way, but not do it themselves. Yeah,
Um, this is an interesting question around the process of dying. Is it peaceful when somebody uses MAiD?
yeah. I actually appreciate that question because until recently that hasn't even been a question. Um, so let me say that I'm not going to get into numbers, but I have done this hundreds of times. I'm in touch with people who've done the same, and I'm involved in a community of people who've done the vast majority of assisted deaths in this country. And I can tell you unequivocally, this is a peaceful process. This is a process without getting into the granularity of it. 99.9% of cases are clinician administered. We give a series of 4 medications, and I'll tell you exactly what happens. The first medication we use is an anti-anxiety medication. It relaxes people, it makes them feel good, and the dose, although not huge, is large enough that 99% of the patients I give this to will fall into a light, comfortable sleep when I give the anti-anxiety medication. They close their eyes, I hear them snore. The family is relieved because many of them were suffering in some way, their symptoms are gone, they're resting. And we see that physically in front of us, we hear them at rest. So that's the first medication we give. The second medication numbs the vein in the arm that we're using. Not everyone uses it, but I always use it. It's the local anesthetics, like when you go to the dentist, so that for the other medications I'm putting through, there's no chance they can sting or create some sort of discomfort in the arm. So we do that second. They're probably not necessary because they're sleeping in front of me, but I do it anyways to make sure they're comfortable. The third medication we use is what we call a coma inducing agent. It's what we use to put people to sleep at surgery in the hospital, but we use a very large dose. So we have a patient in front of us who's gone to sleep with the first anti-anxiety medication, whose vein is now numb so they don't feel any medication, and I give them the medication that will put them into a deep unconscious state. They're not even aware of that happening. They're going from a light, comfortable sleep down into a deep, deep unconscious state, like in surgery, but deeper. And in fact, during that deep unconscious state, to be blunt, that takes away their drive to breathe. They slow down their breathing, they stop breathing, and most patients will die at that point. But we actually don't count on that, although I see it happening in front of me every time and we document it. We always use a final medication to make sure there's no muscular movement in the body in case for some reason, we just need that final. We don't always need it, but we always use it. And this is the process I see. Someone goes to sleep, they go deeper to sleep, the breathing spaces out, they become unconscious. It's somewhere along that route they die, and I make sure this is happening over the course of about 8 to 9 minutes. This is a very peaceful, very comfortable, very dignified process. I have never seen it otherwise. I'm not aware of cases of otherwise. I'm aware of stories in the media that are anecdotal where people suggest it may not be like that. Those are accusations that are made by people who've never been to a MAiD death and have never done a MAiD assessment, and they actually don't know what they're talking about.
Thank you for answering that question. And I found any kind of hesitations I had around what that process might look like. I found your book very it relieved a lot of those anxieties around what that
Yeah.
end of life would look like, with such beautiful stories of people being surrounded by the people that they loved most, and having the music playing that they wanted and the setting that they wanted, and very, very touching.
Yeah, thanks. And I think it's a rational fear. I mean, we're all quite nervous. We're nervous about death in general. We're nervous about how our own deaths will be if we're ill. And then we think we might have found this solution, and we're nervous about what that looks like. It's a really good question. It's a question that should be asked. You should get a good answer to. Luckily, there is an answer.
Thank you.
Yeah,
Well, there are still a few questions coming in. I think maybe we'll have one more and then
that's
we'll
great.
wrap up today. Thank you everyone for the amazing amount of questions. This has obviously been a very informative presentation. So thank you, Dr. Green.
A pleasure.
Um, okay. So there is a question around, you touched on this a little bit, but the individual's asking for a little bit more clarity. I believe if the person is living with dementia, they have provided advance final consent waiver, but now they are sort of happy and content. They may not be aware of some of the things that were troubling them when they signed that consent. If you were, I guess, their practitioner, what would you do most likely in that situation? Is it often that people are no longer given MAiD because they don't seem to be in imminent pain or
Well,
suffering?
see, so this is the crux of the matter.
Yeah.
So a patient who signs a waiver and is intending to use their waiver because they're suspecting that they're about to lose their ability to make their own decision. That has to all be true before they can get into a waiver. They have already met all the eligibility criteria, right? They're already saying they're suffering, they're already in an advanced state of decline, they had capacity, they've met all the criteria, and they say, look, I know this is coming. I want to sign that waiver. And when I'm really unable, when I've lost my capacity to make my own decisions, I want you to go ahead. And this is the date I want it to happen. And it's in the not too distant future. That's the situation that's being described.
Hmm.
When I go on that day, I ask and see if they still have capacity. I hope that they do, but they don't. It's my intention at that point to live up to my commitment, which is to provide MAiD. We made a written agreement together, and I promised I would help given all these situations, which are now true. So it's my intention to go and do so. I will try my best. I will go with the intention of doing so. I will have my medications. The family will know what's happening. It'll all have been planned. The staff at the facility, it'll all be planned to go. If the patient shows or demonstrates in any way refusal and says, I don't know what you're here for. I don't want any medicine today. Or I go to put an IV and I start explaining what I'm doing. They say, no, you can't do that. I don't want that. I'm going to chair. If there's any signs of refusal, I must stop. I'm not allowed to go ahead. The waiver is no good anymore, and we're done. So if the patient is in enough clarity to understand what's happening or not be refusing, I will go ahead. But at any time and every time the patient retains the right to refuse MAiD, they may no longer have the ability to consent to MAiD, but they never lose the ability to refuse. So it depends on what happens that day.
Thank you. I think that's helpful. Thank you.
And
All
that's
right.
obviously a good protective maneuver, right? Patients should never, they should always be willing. You never want a refusal. Yeah,
Absolutely. So no matter what, at any point, someone can always refuse.
100%. Change their mind, refuse for whatever reason. Yeah,
Okay. Thank you.
good.
I'll bring the question period to an end. Thank you everyone for all of the amazing questions. I'm sorry if we didn't quite get to all of them, but I think there is a lot of interest in this topic.
Yeah.
Please do check out the helpful resources document that is in the chat box. So thank you, Dr. Green, for being here today. We greatly appreciate the information that you've shared and providing some clarity around this complex topic when it comes to MAiD and dementia.
Thanks very much for having me. I think it's a really great engagement with the audience. You obviously have well-informed people who are seeking the details. It's great.
All right, everyone, I will mention that if you have any additional questions, please feel welcome to call the First Link Dementia Helpline. It's available Monday to Friday from 9 a.m. to 8 p.m. at 1-800-936-6033. We also have culturally and language specific support available in Cantonese, Mandarin, Punjabi, Hindi, and Urdu. And so you can learn more at alzbc.org/DHL. All right. Thank you all for being here and joining us today for this wonderful presentation by Dr. Green. I hope that you found it informative and I hope many of your questions were answered today.